Sir, we are live now. Now we can start the session.
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have our chairman, Dr. John Mukhopadhaya, sir, who is teaching us about
What happened?
one of the surgical emergency in orthopedics, that is compartment syndrome. So what you
So, is there a problem with the bandwidth? Or can you hear me? Can you hear me?
I'm able
No, because you're coming.
to hear you,
Yes,
sir.
sir.
Please. Yes, sir.
Yes, John, sir.
Please
We
share
can hear
the
you. I
screen,
think
sir.
there is something problem from Janki sir side.
Yeah,
Yeah.
I think the problem, Janki, your internet is probably not stable. Okay, so I'll get
Oh,
started.
I'll just check, sir.
Good evening, everybody. Today was supposed to be Dr. Vikas Agashe giving his talk on upper limb compartment syndrome, but unfortunately he was stuck in hospital and was unable to make it home on time. So in the interest of not missing the class today, I'm going to talk about compartment syndromes in general, okay? Now, remember that this is one of the really urgent problems in orthopedic surgery. And we really need to understand what is compartment syndrome, look at the etiological factors, the clinical features, and the treatment. So any clinical condition in which increased interstitial pressure in a closed compartment results in microvascular compromise and possible myoneural damage is what a compartment syndrome is defined as, and this was given by Mubarak in 1976. The history of compartment syndrome is interesting because it was Folkman in 1881. He described the condition of irreversible contractures of the flexor muscles of the hand due to the ischemic process occurring in the forearm. And this was the term Volkmann's ischemic contracture, which was given to that. Now, what it does is that the increased pressure compromises the tissue. So what happens is the blood flow is disturbed, the oxygenation of the tissues is disturbed, the function is disturbed, and eventually the vitality and of the tissue is affected and the tissue can necrose. Okay, so this mainly involves the nerves and the vessels, and therefore, whenever there is a closed pressure, a closed anatomic space, you can have an increase in pressure, which will result in the damage of nerve and tissue. Okay, now acute compartment syndrome is a limb-threatening and life-threatening condition which can occur as a result. Now, this is different from crush syndrome or chronic compartment syndrome or Volkmann's ischemic contracture, which is a more chronic form, which is a result of compartment syndrome and vascular injury. Okay, so here in crush syndrome, the primary necrosis of muscles is due to a crushing injury, which leads to a cycle of events which can cause acute compartment syndrome and severe systemic effects. And this is common in earthquake victims. Volkmann's ischemic contracture is really a sequelae of untreated or inadequately treated compartment syndrome, as I mentioned, and the ischemic muscle and nerve tissue is replaced by fibrous tissue. We also have the chronic compartment syndrome, where you have recurrent syndromes, which is characterized by pain and disability with exercise or work. This subsides with stopping precipitating activity. So if walking causes it or running causes it, if you stop that, the pain and the effects of the chronic compartment syndrome are mitigated. So if you again then return to the activity, this will again resume the activity of the compartment syndrome and you end up with symptoms. Now, in compartment syndrome, for the etiopathology, there are certain requirements. One is a closed osteophyseal compartment, as you have in the forearm, the leg, even in the femur and humerus. There's an increase in the volume of contents because of the tissue edema or swelling or whatever. And there is a decrease in the volume of compartment. This can be caused by casts or tight bandages, etc. Okay. Now, once there is an increase in content, this can be due to long bone fractures, and open fractures are not exempt. Remember, just because you have an open fracture, it doesn't mean you cannot have a compartment syndrome. You can have it in high energy trauma, in penetrating injuries, in venous injury, crush injuries, deep-seated infection, and the use of anticoagulants. Okay, now the decreased in space could be due to burns because of the cicatrix. You can do it in casts which are tight. You can have it by lying on a limb, especially in patients with drug abuse. And also something which was used for acute trauma, the MAST or the military anti-shock trousers, as it was called, has become less used today because of the problems of compartment syndrome. Now, due to the most common cause is following tibial shaft fractures. You can also have them following forearm or supracondylar fractures in children especially. Okay. And you can have it in proximal tibial fractures, especially the Schatzker 5 or 6 fractures. Now, what is the pathophysiology? It is basically an increased pressure in the compartment. This leads to an increased venous pressure. It also leads to capillaries collapse. This causes decrease in tissue perfusion, and no oxygen is available for cellular metabolism. In severe cases, there's also release of vasoactive substances, which increase the endothelial permeability. Nerve conduction slows. There's anaerobic metabolism and muscle necrosis. Myoglobin production is increased. Within 6 to 10 hours, muscle infarction and nerve injuries results. There's this concept of critical closing pressure. So if your compartment pressure rises to 30 millimeters of mercury, it is considered as an absolute number by Rorabeck. Matson, on the other hand, said 45 millimeters of mercury was the absolute number. We talk about the delta pressure, where delta pressure is the diastolic pressure minus the pressure in the compartment. And if this is less than 30 millimeters, that is what is probably the most or the best way of defining compartment pressure or diagnosing compartment pressure. Or less than 40 millimeters of mercury when the compartment pressure, where the mean arterial pressure is taken as the delta pressure. Okay, so that's the different ways you can do. You can take diastolic pressure or the mean arterial pressure. Okay, so it's a diastolic pressure plus 1/3 of the pulse pressure. Now, timing. Muscle has the capacity to regenerate if release is done early. How early should it be done? How late is too late? This was what was looked at in this landmark study by Hayakawa in 1900 fasciotomies. They found that if you did it in less than 6 hours, you ended up with almost a 90% recovery. If you did it in less than 12 hours, you probably had a 60 to 65% recovery. And if it was more than 12 hours, then you only had around a 10% recovery. Okay. Amputations is a significant number. Overall, it's around 5.5%. If the fasciotomy is done after 12 hours, it's as high as 14%. You can also have deaths. And if fasciotomy is done after 12 hours, the incidence of death is close to 5.5%. Now, nerve ischemia, if it is less than 1 hour, there is normal conduction. In 1 to 4 hours, you can get neuropraxic damage, which is reversible. And if it is more than 8 hours, then there are chances of they're getting axonatomesis and irreversible damage changes, which is shown by Hagens et al. In 1979 in the JBJS. So, acute compartment syndrome is a true surgical emergency. The treatment or the release should be done as soon as it's possible. If treated late or inadequately, can devastate limb or life. And the diagnosis is essentially clinical. Okay? So what it is the compartment pressure tends to be highest close to the fracture site. Now, diagnosis is made by history, the clinical examinations. We all have heard of the Ps. The compartment pressure can be measured where it's possible. They have a special instrument for that, especially the striker, but it's not widely available. And you can get corroboration with lab tests such as CPKs and urine myoglobin. Now, the so-called classical 6 Ps, which are defined in the diagnosis of compartment syndrome, include pain, pressure, paresthesia, paralysis, pallor, and pulselessness. Now, the problem is that the first 3, you're probably still in time to do the decompression. Once you get paralysis or pallor or pulselessness, it is already too late. Pulselessness is not a sign of compartment syndrome, and very often the pulse will still be viable or still be palpable in a patient who has irreversible compartment syndrome, because it is not the pulse that goes, it's the difference between the tissue pressure or the tissue pressure as opposed to what the diastolic pressure or the mean systolic pressure is, which will result in this development of the poor circulation or poor oxygenation of the tissues. Okay, so by the time you reach this, it is already too late, and you'll end up with problems such as this, which will end up with needing to amputate the limb. Okay, now, if you look at the 3 clinical findings which I talked about, if you have only one, then the risk is 25%. But if you have all 3 of the first 3, then it is as high as 93%. Okay, these are various methods which were used to measure the compartment pressure. There's this wick which goes into the compartment and is connected to the syringe, and this is connected to a barometer. Okay, the striker has a machine which you can directly measure the compartment pressure, although they apparently no longer make it, and it's no longer available in India. Okay, it's actually a simple tool which is easy to measure with, but today it's not available. Now, you should measure the pressure close to the fracture site, because various studies have shown that the highest compartment pressures are at the fracture site. Now, when should you measure the pressures is especially important where you have obtunded patients, where patients who have regional, especially epidural anesthesia, if there's a vascular injury, or confirmation of a clinical examination. As I mentioned, wherever the differential pressure is less than a certain amount, okay, this is more important than the absolute pressure. And this diastolic pressure minus tissue pressure, if it is less than 30 millimeters, the chances are the tissue is not being perfused adequately and you need to do something. Now, as I mentioned, the most common sites are the leg, the next is forearm, and you can have compartment syndromes in the hand, the feet, the thigh, and the gluteal region. Now, we all know that the leg has 4 compartments. You have the anterior, the lateral, and the superficial and deep posterior compartments. So each compartment has one nerve, like in the lateral. These are diagrams courtesy Vikas Agashe, which we kind of got from him many years ago. But these are nice diagrams, which you can see the lateral has the superficial peroneal nerve. The anterior has the deep peroneal nerve. The superficial posterior has the sural nerve. And the deep posterior has the posterior tibial nerve. Okay. Similarly, the forearm, there are different compartments, but here the anterior compartment is really very important. You have the superficial anterior and the deep anterior. You also have the mobile VAD of muscles on the lateral side, and you have the dorsal muscles, which form different compartments, but are not always involved in a compartment syndrome. It's important that in the upper limb, the nerves that are there, the median nerve, the ulnar nerve, as well as the anterior interosseous nerve, can be involved in the compartment and can get damaged. So what are your aims of treatment? Is to get back normal function. You don't want any deformities and you want reasonable cosmesis. So in the acute stage, if there's a cast, remove it. If there's a dressing which is tight, split it down to skin. Elevate the limb only to the level of the heart. So you don't want high elevation because that will increase the amount of force that the blood is needed or the pressure that is needed to supply the limb. Okay. An elevation of 35 centimeters reduces perfusion pressure by 23 millimeters of mercury, which was shown in this experiment by Stiff and Weigel. Now, management, which is medical, is really very minimal. People have tried intravenous mannitol. Some people have even tried hypovolemia, but that may aggravate the ischemia. And some people have even tried diuretics. However, the management is essentially surgical. And in the surgical management, what you require is urgent fasciotomies. All tight compartments must be released. You have to excise any necrotic muscles. So you look for the various signs of necrotic muscle. So wherever the muscle contractility, you need to look at the color. You need to look at whether the muscle, the kind of feel of the muscle, those things which will tell you that the muscle is no longer alive. You would usually require to stabilize the fracture, although this is mostly external fixator, but occasionally internal fixation. And then you have to plan your further wound management because once you've opened the compartments, you can't close them by sutures. So you have to think of methods by which you can close this compartment over a period of time. Today, vac dressings help. You can put bootlace sutures and gradually tighten them, or you have to use split skin graft. Now, classically, the lower limb is decompressed through two incisions, one which is anterolateral and the one that is posteromedial, and the compartments close to them are released through it. Now, there are people who feel that one incision is better than two incisions, but I feel that this may be possible in early compartment syndrome. Once the compartment syndrome is really established, you need to decompress the individual muscles also, and that is very difficult through one incision. So remember, you have to protect the nerves and the vessels when you do your release. So don't damage these when you're doing your compartment release. You need to look at, especially posteromedially, the deep vessels and nerve, and anterolaterally, you need to look at the superficial peroneal nerve. Okay, so the posteromedial incision is usually along the medial border of the tibia. So distally, watch out for the vessels. Now, here's a patient many years ago who had a really bad pilon type of fracture. He was admitted in the ward, and when I saw him on the ward round, he had absolutely no movement left. He had some tingling still there, but mostly there was no movement. And you can see the kind of compartment syndrome with blisters forming. And so we took him immediately to the OR. We decompressed all the compartments. We also decompressed the foot because the compartment pressures or the tension sort of extended to the foot, and then we were able to save the limb. Now, what you need to avoid is incomplete decompression such as this, where a fibulectomy was done, and then rest of the compartments were left alone. And really, when he came to us, we had to do a very extensive decompression to get this limb to survive. Okay. Now, what are the complications? One is irreversible neurological deficit, muscle contractures leading to VIC, myoglobinuria and renal failure. This can even lead to death, so you have to be careful about that. Okay. Now, there are some complications of fasciotomy. They include things like the scar, the contractures, infection, nerve injury, vascular injury, and painful scars. Okay. So the basic algorithm when you are dealing with compartment syndrome is, if the clinical findings are unequivocal, you need to decompress the compartment. Where you have equivocal clinical findings, consider measuring the compartment. Where you have no ability to measure compartment, watch it, but if the thing is not improving rapidly, go ahead and decompress. Again, in unresponsive patients, again, measuring the compartment pressure is important. But again, if you clinically suspect it, the idea is to go ahead and do your decompression. So you have to have a high index of suspicion. You need to evaluate these patients repeatedly. You need to do early adequate fasciotomy and debridement of necrotic tissue. You need to do skeletal stabilization, and you need good support from intensivists in some cases. So patients who go sick, you need to watch them very carefully. Okay. Now I'm going to show you one case where we have done the decompression. So there are videos in it. So hopefully that will be useful. Let me see if I can get that. Maybe I have to stop sharing and get that. Okay, for this. Hey, stop it. Let me see now if I can share. Yeah, I think it's this one. Let's see if that works. So this is not the patient. This was another case which ended up. So this is the patient. Those were the X-rays when he came in. That was his clinical findings when he came in, and he had a frank compartment syndrome, which we had also measured the compartment pressure, and it was high, and we decided to decompress. So you can see now, as we are making the skin incision, this is the anterolateral. So we don't worry about the blisters if we are doing a decompression of the compartment syndrome. And you can see that once we get into the superficial tissue, there's some bleeding, but then it's the fascia which is really tight. Okay. So the next step after you've done your skin incision is to divide the fascia. Okay. So this is the skin incision, you extend it, and now you can see the tight fascia over the muscle there. Okay. Now, as we divide this fascia, you can see how the muscle underneath it just bulges out. Okay. See that? It just bulges out, and it just shows you what kind of pressure the compartment is in. Okay. So you go ahead, you go all the way, make sure you release the compartments, stop any bleeders along the way. And you have all these fascias which can cause tightness of the muscles, and even individual muscles you may need to release. Okay, so even we go to the lateral compartment, release not just the compartment but also the muscles individually. Okay, we then go to the medial side where we make a posteromedial incision. Okay, this again extends up all the way to the knee joint and down almost all the way to the ankle. Okay, because lower down there is not much muscle. Okay, so there you go. So now again you can see how the muscles bulge the moment you release the compartment. Okay, so that's the deep posterior compartment we've got to on that level. Okay, the superficial has already been released, and then you go ahead, you release all the muscles, you make sure that there's no single muscle which the fascia is tight over, and then eventually once you've done the decompression, you need to make sure that the vasculature is okay. In this case, we had to actually extend on the medial side to above the knee joint because, as you can see, there was some fascia, some sort of pressure extending to the thigh. So don't hesitate. Go ahead and decompress everything that you need to till you are sure that the vascular supply or the tissue perfusion reaches a stage where you can now rely on it. Okay, so that is where we ended up, that we had to put an external fixator, and then he went on to do quite well. So I'll just stop there just to show that that's how you do your decompressions, and so that we can take any questions now because it's almost half an hour. We can't hear you, Janki.
Yeah.
Okay.
Sorry, sir. Sir, while we are waiting for a question, one thing, sir, how often we require a foot compartment to be released with this leg?
Not often. That was a distal tibial fracture, so it communicates with the foot very easily. But the proximal tibia very rarely will need to decompress the foot. Also, there's some controversy about the releases in a foot compartment syndrome because of two reasons. One is that the incisions can cause problems with your final fixation of fractures in the foot. If you have a foot injury, and the second thing is that the problems associated with foot compartment syndromes are not as serious as that with problems in the leg or in the forearm. And therefore, some people say they don't release compartment syndromes in the foot because if at the most you get clawing, you can release the clawing rather than risk doing some problem with your fixation because of your incisions. Okay. But I would feel if there's a significant swelling, I still feel decompressing it really helps because the swelling goes down very quickly.
There are a few questions, sir. One, Dr. Saswat has asked, what are the signs of adequate decompression?
So what do you look for in the muscle? Okay, one is you want to see that the muscles have bulged out adequately. You need to see the contractility of muscles. So when you nick them or pinch them, they should contract. You need to look at the color of the muscle. It should not be brown or look so it should look vascular, not dysvascular. Okay. And the third and most important, third thing is that you should also look at the consistency of the muscle. So once the muscle is dead, it has a different consistency altogether, which is very clear. So you scoop it and the whole thing comes off in your. Okay. So these are the things you look for. And you make sure that all the muscles within the area are adequately decompressed. Okay. So that is where incomplete decompression can cause a problem. Okay. You may decompress the compartments, but sometimes the epimysium over an individual muscle may still be tight for that muscle. Okay.
Yes. So Rajan has asked, how to be sure that all compartments are decompressed?
So you have to know your anatomy and know all the compartments here. Okay.
Yes,
So.
Sir, Dr. Anand has a question that after decompression, how close structures
How to
is
close?
only stay suture? Do we close the structure or we do stay suturing?
So you can almost never close a established compartment syndrome right away, huh? So you have two options. One is let this thing settle down, then skin graft it, or you try to get closure by a combination of VAC and bootlace sutures, which you gradually tighten. As the swelling comes down, you can get the skin edges to come closer together and suture them. Okay, so those are, so because skin grafting involves a second procedure where you take skin from somewhere, put it over that area, but it works very well. But so you have to see where the swelling is not so much. If you can close it, it definitely makes the scar better, etc., in terms of the patient.
And so, yeah, I think that one is a question that's also. So, I think if there is any other doubt, you can ask. Okay, sir. So,
Okay, so thank you very much. I'm sorry this was a last minute kind of presentation because Dr. Vikas couldn't make it. So hopefully,
yes.
so if there are any questions later, you can ask them later. Okay, thanks. So I
Thank
think
you, sir.
we'll
Thank you very
close that.
much.
Sure.
Thank
When
you.
do we start the other meeting?
Yes, sir. 7:45, sir.
7, so another 15 minutes.
Yes,
Okay,
sir.
sure,
Thank you, sir.
sure.
Thank you very much, sir.